So good evening, everybody from EIZOC Secretariat. We are here again together for being at the part of the webinar, Ophthalmology Resident Training Series number 2. ORTS will be giving us a platform for the young generation to come up with academic activities, and as a whole, with this type of program, the bond between the states of EIZOC bond between the
Switch off one.
one second, sir.
Your microphone is off. You are muted. You need to unmute yourself.
Hello.
Yeah,
Yes.
yeah. Now
I
you
can
are
hear
on.
you.
Our chairman, some echoes are coming up.
No, because you have joined
No,
through 2 devices. This is yours.
Okay, okay.
No, no. One is moved.
Is it audible now?
Yes, yes.
Yes.
Please carry on. Yes.
Our chairman, Scientific Committee, Dr. Sabyasachi Patnaik, has framed the webinar in a meticulous way, supported by the Chief Coordinator, Dr. B.N.R. Subudhi sir, and the Coordinator, Dr. Ashok Nanda and Dr. Anurag Mishra. The program is mentored by none other than our past President of AIOS, Dr. Ajit Babu Maji. The speaker of the evening will be Dr. Jyotirmoy Biswas from Shankar Nethralaya, Chennai, Ultimate Authority of Uveitis. We had also a galaxy of panelists who are the masters in the field of uveitis and discussant, and they are chosen from different academic institutions across the country. We plan to do this type of webinar regularly. In addition, our new chairman ARC, Dr. YC Miti, is also planning to have few ARC activities. Our midterm conference will be on 27th and 28th August at Port Blair. And those of us yet not registered, please do it immediately and be a part of the great event. Thank you. Is it still echoing?
Thank you, sir. Thank you very much. Now I welcome everybody for this program. The second is edition of ORTS program under the banner of EIZOC. I welcome Dr. Jyotirmoy Biswas. We are very fortunate and lucky to have him amongst us. And I was very unfortunate because I had to abandon my training under him, 2 weeks observership training because of this corona. So I am again waiting for that opportunity, sir. Thank you very
You're
much.
welcome, sir.
Sir, thank you very much for agreeing to our request, and thank you. Now I request Professor B.N.R. Subudhi to start the proceeding of the program. Thank you, sir.
Thank you, Dr.
When the
Swaraj.
EIZOC video should be shown.
Yes, show it. You want to show it? Show it.
Today's little disturbance is there. Can you see it now? Not yet.
It's set. Set. You can.
Yeah. It will come. So I have to share the screen. Yes.
Yeah.
Yes. Yes, sir. Can you see now? I think all those who are regularly joining us, they see it very often. Anyhow, over to BNR Subudhi, sir.
Thank you, Dr. Sura, Dr. Sabasaj Patnaik, for the nice welcome. I welcome once again to all the participants of this, our second in series, ORTS series 2. Today's topic is being Panuveitis, and I won't take much time. Sorry. Let it go like this. It's not moving. Yes, this is our team. I don't want to go into details because already time is lost. So let me go to the speakers. Today's speaker is none other than Dr. J. Biswas. So Dr. Jyotirmay Biswas is well known to all of us, and he is presently the director of Uveitis and Ocular Pathology departments of Shankarnath, Chennai. He has an MBBS from the Medical College, Calcutta, a postgraduate degree in ophthalmology from PGIM, Chandigarh, and held a fellowship in vitreoretinal surgery at Shankarnath. After that, he had a fellowship in ophthalmic pathology from Doheny Eye Institute, University of Southern California, USA. He has published so many papers. I have selected only this much only. Dr. Biswas has published 358 articles in peer-reviewed journals and 47 chapters in ophthalmology books. He has written 5 books on uveitis and 1 book on ophthalmic pathology. He has presented 202 papers and given 272 lectures at national and international conferences. And he has reviewed 36 journals and received more than 32 awards, and the most notable being the Hari Om Ashram Alumnic Research Award from ICMR, given the President of India. So this is a short and brief introduction I give to Dr. Jyotirmay Biswas. I welcome you, sir, to today's webinar. And today's discussants, we have got panelists, 4 panelists. Dr. Satyajit Sinha, very famous from Patna, from ABI Institute. Professor Sumita Mahapatra, SC Medical College, Professor, Head of the Department. Dr. Ravindra Chaudhary, Assistant Professor, Bimsar Burla, and Dr. Vibhuti Kashyap from Kashyap Eye Hospital, Ranchi. So these are our 4 panelists, and our discussions today: Dr. Asmita Pradhan from Bimsar Burla, Dr. Shubham Harsh from RIMS Ranchi, Dr. Aishwarya Bhakta from Agrawal Eye Hospital, Cuttack, Dr. Niranjan from RIO Cuttack, and Dr. Lisa Kuli, Assam Medical College, Dibrugarh, and Dr. Megha Banka from RIO Kolkata. So we got a wide variety of students from all the states of EIZOC. So I welcome you all, panelists, and discussions to today's program to make it a lovely program and lively program too. So I thank you very much for joining this program. Let us start the program. It's over to Dr. Ajit Babu Maji for brief introduction and start the program. It's over to you, sir, Dr. Ajit Maji. Where is Dr. Ajit Babu? I think Dr. Ajit Babu is out somehow. So he will be joining. So I think it's over to Dr. Jyotirmay Biswas. Sir, you can start the program.
Before that, I think there should be case presentation.
There is a case presentation.
Yes, before Dr. Biswas starts. So let the case presentation by Dr. Asmita.
Then we will have a discussion.
Yeah, Dr. Asmita, over to you.
Just start the case.
লাইটটা বন্ধ করো তো।
Can I start? Shall I start?
Yes.
Yes, you can start.
Good evening, everyone. The patient is a 51-year-old Hindu female resident of Khetrad to Sambalpur. She presented to us with complaints of diminution of vision. It was gradual in onset and progressive, associated with metastasis of intermittent pregnancy since 2 months. The patient had given us a history of receiving treatment for these complaints elsewhere with topical steroids, topical cycloplegic, and topical antibiotics previously. In the past, like diabetes, hypertension, tuberculosis. Family history, nothing significant. Personal history, the patient had no complaints of arthralgia, hair loss, chronic cough, weight loss, fever, oral ulcers, genital ulcers, rashes, or any abnormal bowel habit in the past. On general examination, the patient was conscious and oriented to medium of moderate build, well nourished, head was lifted, and no facial asymmetry was present. His both eyes were orthophoric. On ocular examination through slit lamp, lid and the entire anterior segment visualization of right eye on slit lamp examination was with the normal limit. On left eye slit lamp examination, there was presence of Cope's nodules on the pupillary margin of left eye, along with some amount of pigment dispersion over the anterior lens capsule. These are the diagrams of the left eye showing Cope's nodule in the pupillary margins along with pigment dispersion over the anterior lens capsule. The visual acuity of right eye was 6/12, while left eye it was 6/18. Intraocular pressure measured through non-contact tonometer was of right eye was 13 millimeters of mercury, and for left eye it was 16 millimeters of mercury. The fundus was evaluated, and on an evaluation we found presence of multifocal serpiginous choroiditis patches of left eye, as well as a developing active focal choroidal patch in the right eye. There was presence of hyperpigmented choroiditis.
Smita, just a minute. Yeah. While describing the lesions of posterior fundus,
Yes,
you should describe in more detail. Last time also we have told you, the shape, what are the margins, center, how it is, whether it is active or not, adjacent vessels, they are affected or
Start
not.
from the media.
The media.
yes, sir.
Start from the media, and then which eye, then macular area disc and rest of the fundus. But while describing the lesions, you should describe in more detail. Try to do that.
Okay, sir.
Yeah.
On examination, the
Can you
media.
turn on your video as well?
Sir,
Your video. Your face is not seen.
sir, should I stop sharing the screen?
No. You keep the screen, but your face is not to be seen.
See, I just joined through the, mobile.
No, it's okay. It's okay. Continue your presentation. Let's
Continue.
Carry on.
So the media for both the eyes on visualization for fundus evaluation, media was clear, and there was as we can see through this, on left eye examination we can see there were multifocal patches present diffusely through the fundus, and there was whitish yellow in color with pigmented margins. There were well-defined margins, and while in right eye, there was presence of whitish yellow chorioretinal patch along the along the macular region, and the margin was not well defined or well circumscribed, indicating a more active lesion. And it was only one focal lesion, while there were multifocal lesions in the left eye. Further, the patient was investigated. Routine complete blood count was sent, in which lymphocytosis was found. Viral markers for HIV.
What was your Ashmita? What was your working diagnosis at this stage? Investigations will come later. What is your
Yes,
working diagnosis?
Provisions.
Sir, due to the presence of focal multifocal choroidal lesions in the posterior segment in both eyes, and presence of Cope's nodules in the left eye, at this point of time, I think the provisional diagnosis would be a chronic granulomatous panuveitis left eye and posterior uveitis right eye, and Sir, due to lack of most likely of in sir
It's okay. As long as means as much as you can, you just tell, because
Yes.
JB will highlight in his presentation what all lesions you are showing here. Whenever it is bilateral, again the diagnosis will inclusive of both the eyes rather than single eye diagnosis. There can't be one posterior uveitis and one as panuveitis.
Okay, sir.
The
Okay, sir.
panuveitis.
Yeah. Once it is panuveitis, it will be panuveitis. He will present it anyhow. Yeah, go ahead, Asmita. You are doing well.
Yes, sir. The patient was then further investigated. In routine blood count, there was presence of lymphocytosis. Viral markers for HIV, HBsAg, and HCV were negative. Blood glucose, urine routine microscopy was within normal limit. The patient had a ESR of 38 millimeters at the end of first hour. VDRL through RPR was non-reactive. IgM and IgG for toxoplasma was negative. RA factor was negative. The patient had a Montauk's test positive, measuring 25 millimeters. The patient was advised chest X-ray PA view, following which, due to presence of focal old lymphadenopathy lesions, the patient was further advised by HRCT chest by medicine department, and also advised interferon gamma radioassay test, which turned out to be positive.
What is the location of lymphadenopathy in your case? You
Sir,
said focal lymphadenopathy. Where was the location?
Was
so
it
it was mostly
hilar?
in the perihilar region.
Okay.
Right. Yeah, go ahead.
So at my provisional diagnosis is chronic granulomatous panuveitis with possible infectious etiology, most likely tubercular in origin. The patient was then referred to pulmonary medicine for further investigations and initiation of anti-tubercular treatment along with systemic steroids. This is the fundus picture of the patient 6 months following initiation of anti-tubercular treatment.
Ashmita, before going to treatment,
Yes,
how would you confirm that this is serpiginous, one thing, and second, whether it is active or not?
Did you do
Antichoroiditis.
autofluorescence angiogram?
Yeah, JB, let them come out first, and anyhow in your lecture you will cover the whole thing.
Sure.
Yeah, just want them to think first.
Okay.
Ashmita,
Yes, sir. So serpiginous lesion is something which should start from the optic disc, and then the lesions further spread along the arcades or throughout the rest of the fundus. And in case we have to tell if the lesion is active or chronic, usually active lesions do not have well circumscribed margins. They have very diffuse margins, yellowish white in color, central opacity. And in case of chronic lesions, the margins are well defined, mostly associated with some amount of pigmentation, choroidal pigmentation, hyperpigmentation. And while in active lesions, the margins are amoeboid usually.
can you show the picture of the right eye? Right eye fundus picture. Fundus
Right.
photograph of the right eye. Yeah.
Sir, this
Can
is
you
the
tell?
right eye
Yeah.
fundus.
Describe this. See, this is a typical serpiginous choroiditis. What you are seeing there. See, the left eye is, as you said, it is multiple localized lesions are there, and it's probably some are active, some are not so active, and it is not in serpiginous in nature. But here, if you see the right eye,
Yes, sir.
what is the center it is looking like, and what edges it is looking like? If you have an observant eye,
Yes, sir.
this is a typical serpiginous choroiditis.
Okay, sir.
Can you see that? Can you see the center, how the lesion looks like?
Yes, sir.
And so once it is serpiginous, what is the most common etiology in our country? Anyhow,
Sir, because we are endemic to tuberculosis, so in tuberculosis is most likely the cause.
yeah. So it's almost like a clinical diagnosis, right?
Yes.
Etiology also is a clinical diagnosis. JB will highlight on that part while during his presentation. And the investigations, which investigations do you think clinically they are useful for you, which are very simple? Whenever we are saying investigations, you should always tell the simplest one to the complex, practical and non-practical also you can tell. Ophthalmic investigations. JB
Yes,
just
sir.
started with his question, but you can highlight on that.
Sir,
Yeah. Aishwarya, can you highlight?
sir,
Sir, fluorescent angiography for the serpiginous choroiditis and USG B scan we can do for choroidal thickening or vitritis, or if there is any complication like exudative retinal detachment or OCT macula for cystoid macular edema or epiretinal membrane. Sir.
Any other investigations? Dr. Lisa, do you want to add any other investigations to whatever Ashmita and Aishwarya has told?
Yes, sir. OCT angiography can be done.
Anything else? More simpler? Actually, JB started with that investigation. They have not listened, JB, to you.
Autofluorescence, sir.
Autofluorescence
Yeah,
would be the
RP
best.
autofluorescence is
thing.
these days, if you think about non-invasive and more simpler is RP autofluorescence. Of course, he will highlight what are the active lesions look like and inactive lesions on RP autofluorescence, but that need to be included in your armamenta of ocular investigations. Okay, go ahead, Ashmita. Continue your presentation. Yeah.
So my presentation is complete.
Complete, over.
Yeah.
What is the outcome? 6 months.
Sir,
What is the visual outcome?
Yeah.
Sir, after 6 months, the patient followed up, and this is the fundus picture after 6 months of receiving ATT, and this is OCT macula performed on that fundus picture.
Yeah. What is the visual outcome?
So visual outcome did not progress much. It was still restricted to 6/12 partial.
Which eye?
So both eyes.
It means when you present, no, you need to keep one slide of final outcome, visual outcome. Second is, how did you confirm that it is completely healed, or are there any patches of activity which are still persisting?
Sir, we have.
It's okay. No, fine, Ashmita, you have done very well. You have done very well. Don't worry. Okay. Because this presentation will make everyone alert about the case, and then now we will proceed to JB. But before going to your presentation, Dr. JB, can you suggest something to the presenter, Dr. Asmita?
See, may I tell a few things? One of the important thing is that focused history. The focus
Yes.
history, you can go back and forth. So after looking at that fundus picture or anterior segment picture, you can go back and ask the question. For example, I see a choroidal nodule or choroiditis or Poppy nodule. I'll ask the history of contact with the family, any tuberculosis, like a close family member having tuberculosis or not. Whether the patient has got systemic symptoms, very focused one, any history of fever, low-grade fever, weight loss, chronic fever, weight loss, these are the things, a cough, anything. But usually, the active systemic tuberculosis is often not associated with tubercular lesion. It is always a latent tuberculosis or healed tuberculosis, which is often associated with the ocular lesions
Ocular
like
lesions.
choroiditis.
Yes.
Looking at the picture of this one is that first you should try to find out what kind of morphologic pattern is there. Is it a focal? It is a multifocal. If it is a multifocal, what is the, whether it's involving the posterior pole, mid periphery, or whole retina is involved. So based on that, you can make a differential diagnosis. And it's also important to look at the media. If there's a vitreous haze is there and localized focal retinochoroiditis is there, you need to think of toxoplasma.
Toxoplasma, yes.
And when you see a geographic border with no vitreous haze, there is no need for doing an ELISA for toxoplasma. Is not required. And you can, that ELISA for HIV should be done in only suspected cases. Venereal TPHA, of course, in any type of uveitis can have syphilitic etiology. And so venereal TPHA would be in your plan of investigation.
Yeah, because syphilis is a big masquerade
Treatable
of,
disease.
with
Syphilis
all
is
the,
a one-time disease and it's a treatable disease. So it should be ruled out. Now looking at the history and the clinical findings, there's a gradual dimness of sudden, not a very sudden dimness of vision. The patient had lesions for that one. If the patient had acute loss of vision, like that sudden drop of vision in a day or two, you need to think about a viral retinitis. So that one of the causes. Viral retinitis also, of course, will not have lesions, vessels going over the lesions. It's a retinitis lesion, and choroiditis is when the blood vessels can be seen over it. And you would be able to do that one much better way to find out, differentiate whether it's a retinitis, choroiditis, or retinochoroiditis by doing an OCT. We would be able to see the level of the inflammation. But a good clinical examination would be able to make it differentiate between the retinitis, choroiditis, which is a very important. Once you diagnose as choroiditis, you need to say it's a round border or geographic border. When there is a geographic or amoeboid, as you have told rightly, it has got a diagnosis of serpiginous choroiditis is the common in your mind. And serpiginous choroiditis has got two typical pictures. One is that classic serpiginous choroiditis, which is peripapillary. Earlier, we used to call geographic helicoid peripapillary choroiditis or GHPC. And nowadays, we see more of a multifocal serpiginoid choroiditis. Multiple serpiginoid-like lesions are seen. Here, one side, you have got a macular serpiginous choroiditis, and other side is having the multifocal serpiginoid choroiditis. Now, several investigations, several studies have shown that this multifocal serpiginoid choroiditis is in our country is often tubercular in etiology. So your investigation should be focused to tuberculosis. So there is no point in doing an urine for examinations. Is that there is should be, I will be top on the list. I'll do a simple test like Mantoux, total WBC platelet count, ESR, Mantoux, quantiferon TB gold test, And the CT chest, probably I will be ordering it if the patient can afford it. The reason is that CT chest has got higher chance of picking up the latent tuberculosis, as is this in this case, hilar bile lymphadenopathy. Hilar lymphadenopathy, when you see that, you need to see that whether it's a calcific or non-calcific. If it is a calcific hilar lymphadenopathy, the TB will be on the top of the list, and this would be an healed tuberculosis. And there is regarding that ophthalmic investigations, you need to go in the stepwise manner. I would try to do a normal fundus photograph, montage fundus photograph. And if I've got optos, I will do the optos, but my first preference, optos sometimes, that it takes the periphery and then central lesion, the margins is not that very well delineated. So I will do that fundus, normal fundus montage photograph, and I'll do definitely an autofluorescence. So autofluorescence will be showing the activity of the lesions, and I'll do the serial fundus photograph and autofluorescence to show that the lesion is healed or not. So autofluorescence, hyper autofluorescence margin will indicate active age of the lesion. However, one can do it clinically also. Clinically, the active lesions will be yellowish in color and the margins will be fuzzy, blurred, and is a thick margin, is a rolled up kind of thing. We will see. In case of clinically, you can make out, but autofluorescence will help you out to confirm the diagnosis of your active, healed, or resolving choroiditis. Resolving choroiditis will be having active hyperfluorescence, hyperautofluorescence at the periphery, and the central area will be hypofluorescent. Then, if I have got facility, I will do an fundus fluorescent angiogram, and fundus fluorescent angiogram initial phase will be hypofluorescence, and then periphery will be lit up at the age as the disease progresses. Fundus fluorescent angiogram is also useful in one of the situations when there is a retinal vasculitis is there associated. So associated retinal vasculitis can be picked up by the fundus fluorescent angiogram, which ICG may not be do that one. ICG is not a must, but ICG can help us to know the extent of the lesion. If the lesion is very close to the fovea, if you do an ICG, you can see that it has actually involved the fovea. The choroidal lesions is much better appreciated or much better delineated by ICG, because the ICG that doesn't leak out and it is got bound to that one, and we can show the extent of the lesion. And some subtle lesions which are not picked up by fluorescent angiogram can be picked by ICG. I should not, I am not very fond of doing an OCTA in such cases, because that becomes is OCTA, though we have just published a paper on OCTA and serpiginous choroiditis. It shows flow void areas, and these flow void areas disappear after a healing phase. But choroidal neovascular membrane is very well picked up. Subtle choroidal neovascular membrane can be very well picked up by OCTA, and which may not be detected by fundus fluorescent angiogram. Regarding the diagnosis part of it, I will make a short clinical differential diagnosis. My top on the list, as has been told by Asmita, is in the tuberculous serpiginoid choroiditis. So I'll confirm with the laboratory investigation, and the patient has rightly been found to be all 2+2=4, that tuberculous serpiginoid choroiditis, and is rightly put on antitubercular treatment. But if the lesion is macula threatening, close to the fovea, I would prefer to put the patient on intravenous methylprednisolone 1 gram daily for 3 consecutive days, because that is the drug which acts very fast in hours and will control the inflammation. It's right away to put the patients on ITT and ATT should be combined with the steroid. The reason is that there can be paradoxical reaction, and even after some time, if you put on the patient for long-term steroid, you can add one immunosuppressive agents like mycophenolate mofetil under the cover of antitubercular treatment. So antitubercular treatment in the ocular tuberculosis or tubercular serpeginoid choroiditis, duration is not 6 months. Pulmonary tuberculosis is treated for 6 months, whereas that extrapulmonary tuberculosis like CNS tuberculosis, the duration of the treatment is minimum 9 months to 12 months. So 9 months minimum treatment I give for antitubercular treatment. Nowadays, there are some other forms of antitubercular treatment. One of the component of antitubercular treatment is ethambutol, which can cause ethambutol toxicity, though is less. But nowadays, we are seeing more and more. I asked my pulmonologist to prefer non-ethambutol regimen like levofloxacin or moxifloxacin, but mostly levofloxacin. This gives a cover of the rifampicin isoniazid, levofloxacin. One of the important tests to monitor that one is the liver function test, because most of the antitubercular treatment, rifampicin isoniazid, has got liver hepatotoxicity. So the pulmonologist all the time asks for a liver function test done periodically. The case has been managed very nicely, and I would not have a different regimen of treatment than the one which has been done, and the patient has improved a lot. If we pick up the case, a diagnosis fast, and you put appropriate treatment, choroiditis is often well treatable. But if you lose some days, like a week or so, that produces in the subretinal scar, and that can cause significant impairment of the central vision. I also often do that when multifocal serpeginoid choroiditis, we have published on paper on visual field to find out, actually, you say the 6/6 vision or 6/9 vision, but the patient often is not satisfied. He said that I can't see that area as a whole, my visual field is not very clear. It might be a good idea to get an in heal stage to find out, or resolving stage to find out that how much the visual field is lost due to the choroiditis. So these are my few thoughts. I think it's very well presented case, well documented. I wish we should have an autofluorescence.
Yeah, which is very simple test.
Yeah.
JB told that OCT to see the vessels, but mainly I suggest that clinically they should identify the retinal vessels, the course of the retinal vessels in relation to the lesion.
Yes.
That will give you most idea. In some cases where there is a severe active choroiditis, certain times it's difficult to trace the vessels. In those cases only, you go for OCT. Means you should rely mostly on your clinical observations rather than a investigation. And if you see, this is a case very typical, even if we do not have the positivity for tuberculosis. JB,
if it's not positivity with tuberculosis, I would have treated him as a very strong suspicion of antitubercular treatment. A Mantoux test is often negative in tubercular uveitis. I will be showing you that one. 40% cases in a tubercular, even that when acid fast bacilli was seen, and it was found to be negative for Mantoux. So it can be there. And so your clinical suspicion is the top on your head. It should be there. And
I think
any evidence, any of the test is positive, you will go ahead with the anti-TB treatment in clinical settings like this.
Excuse me, sir. Can I interrupt?
Yes.
Sir, this case actually, I have treated this case, sir. Now this patient is complaining of floaters. The patient is a very anxious patient. Though he's happy with this ATT and everything, vision is also, with regard to vision also, she is happy. But now she is complaining, she annoyed of this floaters. How to manage that one, sir?
So I think you have to counsel the patients.
Yes.
The floaters is, you know, that in case of intermediate uveitis, if you see floaters, you can treat it, and that may be due to the inflammation, vitreous cells. I would look for vitreous cells. If it is a vitreous cells is not there, I would counsel the patient. If
No
the
vitreous
vitreous cells is there, I will continue the treatment with the antitubercular treatment and steroid. I would counsel the patients. I won't do that any further treatment.
These
Based on the
cases
floaters,
with
I would not.
choroiditis, certain times overlying inflammation, though it is response, it can cause subclinical vitreous changes, which will result in floaters. What you need to counsel the patient is, you have saved this patient from a very dangerous risk of losing complete vision, central vision, which you have saved. And as a aftermath of the lesions, the overlying vitreous, there can be subclinical changes, which they need to accept it as a normal this thing. Because certain times the treatment, you know, is if vitreous changes are there, vitrectomy need to be done, but that is much more dangerous proposition compared to the mild floaters which the patient may be having. So good explanation is very much required, and you should spell out the risk of losing central vision in these patients. That probably make the patient more happy for saving the central vision for them.
Yes, sir. Thank you.
JB, I think with this, Ashmita, it's very beautiful and
Beautiful presentation.
a beautiful presentation, and you have done very good. Okay, good luck, and it's good for your all colleagues also that they are observing, and that they can also do this in front of a very great clinician like Jyotirmoy Biswas. So now we will move on to the main presentation by Dr. JB on the subject of panuveitis. Over to you, JB.
At the outset, I'm really so grateful for getting the opportunity to by the EIZOC on this ORTS, and I like to thank Professor BNR Subodhi, Dr. Ajit Babu, my good friend, Dr. Satyajit Sinha, Dr. Vibhuti Kashyap, and I feel always that the teacher learns the most. As just sharing the knowledge, it gets magnified, it expanded. So what I am going to do is not to teach you, just to share my experience. And what I made it is a very great basic level at the postgraduate level, and very simple few cases. And I'm not going to details. I'll take up the questions later on. Let me share my screen. Hopefully it will work. Is my screen visible?
Yeah, yes.
I'm audible?
Yeah.
Yes,
Yes.
sir.
Yeah. So what I want to do is that talk about panuveitis, clinical feature, differential diagnosis, and approach to management. It's not a theoretical one. What I have done in some of the sitting in my clinic, I'll be sharing that. So to start on the basic, the uveitis IUSG International Uveitis Study Group that I'm a member of that group. They have divided uveitis into 4 morphologic pattern: anterior, intermediate, posterior, and panuveitis. You know all. When we do have all the layers of the middle coat of the eye is involved, that's called panuveitis. And this has been done by the standardization of the uveitis nomenclature group 2005. It's further consolidated that we should call anterior uveitis, not iritis or iridocyclitis or cyclitis, or retinitis or choroiditis. We will call it posterior uveitis, anterior uveitis, intermediate uveitis, and pan uveitis when there is all the coats of the uveal tract is involved. So what is the pan uveitis patients present? They are not like patients presenting with the photophobia that much. They present with a gross reduction in the vision. So there is a gross reduction in vision in a few days or a week time. There might be a pain, there may be blurring of vision, there may be floaters, there may be mild photophobia and the redness. The most important thing is that they rob away the vision very fast. So I'll show the few examples of pan uveitis. Sympathetic ophthalmia. When I talk about sympathetic ophthalmia, I remember of a patient whom I see 20 years ago. This was a 12-year-old boy from Bihar, had bow and arrow injury in the left eye. And this patient lost the vision in the left eye. But after 1 month, he started showing blurring of vision in the right eye. He showed to the local ophthalmologist, and the local ophthalmologist, of course, treated with the steroid, but he was not getting better. So grandfather got worried and he brought the patient to Chennai, Madras that time. And when I looked at the fundus, I found the disc margin is blurred. There was a secondary retinal detachment. And that time that immunosuppressive agent was not in vogue that much 20 years before. But I started using it with my experience at stint at Los Angeles, USA, under Dr. Narsingh Rao. I thought that immunosuppressive agents would be can be added because the patient has already had a steroid. So this was a very initial patient of mine. I treated with azathioprine, a 50 milligram tablet, half tablet 3 times daily, and put the patient in addition oral steroid. The patient got back 6/6 and 6 vision in the sympathizing eye, which is quite gratifying. But that is not the end of the story. The patient contacted me through Facebook and told 20 years after we lost contact, he said that he is doing postdoctoral fellowship in Finland and he wanted to collaborate with me in the research in genetics. So it was one of the wonderful email which I got from in my life, that one of the boy which I've treated in the 20 years back has become a postdoctoral fellow. So this was one of my initial patient of sympathetic ophthalmia. What is sympathetic ophthalmia? It's a rare, bilateral, granulomatous pan uveitis. There are two eyes. One is the exciting eye, which you call injured eye, following surgical or accidental trauma to the eye. Mostly is a penetrating ocular trauma. And sympathizing eye, this is the uninjured eye, developing uveitis after a latent period. So eye is such a wonderful organ, such a peculiar organ, that one eye got injured, other eye has got sympathetic ophthalmia. It doesn't happen with the ear, but it happens with the eye. And there are famous, Louis Braille, who lost the vision, was due to the sympathetic ophthalmia. There are very famous people lost vision due to the sympathetic ophthalmia. This is one of the vision-threatening pan uveitis. So nowadays, what has happened that there are maybe many causes of sympathetic ophthalmia. Even cyclocryotherapy can produce sympathetic ophthalmia in the other eye, which I have reported one case. Pars plana vitrectomy has emerged as an important cause of sympathetic ophthalmia. So sympathetic ophthalmia risk following vitrectomy is more than twice the risk of infectious endophthalmitis. So this is one of the small gauge vitrectomy which has started, and it has found to be one of the important reason which you should not ignore. Particularly multiple vitreoretinal surgery, when the patient undergoes, they can have a loss of vision due to sympathetic ophthalmia. Early examinations, early identification, if we see the vitreous cells in the other eye, you should have a careful examination. Even a OCT, SSOCT can be done, or ultrasound can be done to see that the patient is having sympathetic ophthalmia or not. So we described the multimodal imaging in sympathetic ophthalmia. As I mentioned to you that in tubercular choroiditis or any posterior uveitis, fundus autofluorescence is now emerged as one of the simple tool to identify the status of the lesion. Then we come fundus fluorescent angiogram, indocyanine green angiogram, optical coherence tomography, and ultrasound B scan. In sympathetic ophthalmia, I will first put that ultrasound B scan. Ultrasound B scan will show the diffuse choroidal thickening, mostly in the posterior part. That would be my first investigation in sympathetic ophthalmia. So, for the sake of convenience, I put in the order of fundus autofluorescence, fluorescent angiogram, indocyanine green angiogram, optical coherence tomography, and ultrasound B scan. If I don't have any of the, I will do an ultrasound B scan to see the choroidal thickening. So what we see in fundus autofluorescence in sympathetic ophthalmia, hyperautofluorescence in exudative RD, and speckled area of hyper and hypoautofluorescence resemble leopard spots in resolving exudative retinal detachment. It's not very typical of sympathetic ophthalmia. Any exudative retinal detachment in resolving phase, you can see the speckled area of hyper and hypoautofluorescence. You see the similar thing in VKH. This is the active disease, and you can see that, I don't know whether my cursor is seeing that one. You can see that hyper and hypoautofluorescence. And if it's a healed stage, you will see the hypoautofluorescence. So now we're coming to the fluorescent angiogram. Fluorescent angiogram can be very effective. After the ultrasonography, I would prefer to do a fluorescent angiogram. So it will show pinpoint leak with late pulling of the dye in the like DKH, placoid early block with late stain like APMPP, and disc vessel leakage with staining. And this will be the acute stage. You can get, I'll show a picture soon. Chronic stage, you get the nummular transmission defect, nummular scar, like, and that Dahlen-Fuchs nodule, a gradual hyperfluorescence with staining, subretinal fibrosis. And one should not forget that the patient can develop CNVM, choroidal neovascular membrane, which can be picked up by fluorescent angiogram quite well. So choroidal neovascular membrane is often occurs peripapillary area in VKH and sympathetic ophthalmia. So you should be distinguished from disc edema or papillitis from CNVM, which might be hidden in a case of sympathetic ophthalmia. So here is a very classic example of sympathetic ophthalmia with the sympathizing eye. And you can see the point leaks are there, and in the second frame, and there is a pulling of the dye in the subretinal space and showing that the bullous pockets of subretinal fluid, hyperfluorescence. So indocyanine green angiogram can be helpful. Multiple hypocyanosis spots is seen, cellular infiltration, Dahlen-Fuchs nodule, overlying edema, helps in the staging of sympathetic ophthalmia, fading in the late phase active lesion, persisting in the late phase chorioretinal atrophy. But I would favor getting a fundus photograph of fundus fluorescent angiogram and ultrasound. And here is the FFA showing the initial point leak and with the pulling of the dye in the late phase, lower frames showing that multiple hypocyanosis spots and which fades away in the late phase of the disease. So as I mentioned to you, ultrasound will be my first weapon to reveal the choroidal thickening, medium to large serous retinal detachment. Even a subtle serous retinal detachment can be picked up by ultrasound. and you can compare axial length of the exciting eye and sympathizing eye. If the axial length of the exciting eye is good, there is a still chance of getting back some vision. So we have described the choroidal structural changes in sympathetic ophthalmia and swept source optical coherence tomography. Optical coherence tomography has become an important component of identifying sympathetic ophthalmia or VKH. So what it does show, it shows the bacillary layer retinal detachment, multiple serous neurosensory detachment, and then hyper-reflective safety. You can see the micro hyper-reflective safety, dividing detachment into pockets distinctly, and choroidal thickening. Swept society can be used for the choroidal to detect the choroidal thickening. So choroidal thickening can occur also in case of central cells chorioretinopathy, but you won't see the subretinal septi, which you see in case of VKH or sympathetic ophthalmia. Subretinal choroidal folds or choroidal striae can be seen, loss of physiological choroidal vascular pattern. And then Dahlen-Fuchs nodule, which is classically described in sympathetic ophthalmia, small, irregular, hyper-reflective areas under the pigment epithelial detachments and disruption of overlying RPE. Extension of this hyper-reflective presumed inflammatory material into the outer retina is seen. So Dahlen-Fuchs nodule can be easily seen and identified in sympathetic ophthalmia. And these are the nodules which are seen in the periphery in this case, and which is very typical of VKH and sympathetic ophthalmia, particularly sympathetic ophthalmia. We have got a very nice, I just have got a very nice picture from my path lab, that Dahlen-Fuchs nodule. You can see that arrow showing one of the Dahlen-Fuchs nodule. There is a retinal pigment epithelial atrophy, and underneath the retinal pigment epithelium, you can see the collection of inflammatory cells in the form of lymphocytes and epithelioid cells. And what happens is also the choriocapillaries remain spared. They are not closed, as we've seen in case of VKH, whereas in the late stage,
Hello.
the choriocapillaries occlusions is seen.
Hello.
So, anything?
No. You can continue, JD.
Yeah.
Someone else.
How do I treat a case of sympathetic ophthalmia? My way of treating is the intravenous methylprednisolone. 1 gram daily I give for 3 consecutive days, followed by the high dose of oral steroid. When I do taper the steroid, I do the slow tapering in sympathetic ophthalmia, like not in the case of posterior scleritis or so. So I will do the slow tapering, and over the 6 months of period, and add azathioprine or mycophenolate mofetil. And if not responding, I switch over to the T-cell mediator, T-cell inhibitor, like cyclosporine or calcineurin, that is also called calcineurin inhibitor. This is another case of sympathetic ophthalmia, 7-year-old boy, trauma, right eye with a wooden stick. And this patient had 1 week later, left eye developed sympathetic ophthalmia. You can see the bullous serous retinal detachment, and a visual acuity was hand movement. And I want to show you how the patient has responded to treatment. Swept society showed multiple serous retinal detachment, pockets of serous retinal fluid with subretinal septi. And this patient was treated with azathioprine and steroid. Vision came back to the 6/6 and 6. Amazing. The whole retina becomes, which was a bullous pockets were there, has come back with the OCT coming, showing to the normal foveal contour. And this is a shifting gear from sympathetic ophthalmia to another disease which closely mimics sympathetic ophthalmia is VKH. Is also another common panuveitis, particularly in Chinese and Japanese population. We see also quite a good amount of VKH. This is a 34-year-old man, or it could have been a woman also. 10 days history of blurring of vision, history of fever, 10 days prior to the onset of symptoms. And this patient was seen by another ophthalmologist and was on 80 milligram oral prednisolone, antechamber quiet, few vitreous cells. Base-corrected visual acuity was very poor, 3/60 and 2/60. And fundus fluorescent angiogram, as you have seen in that sympathetic ophthalmia, pinpoint leaks and the pulling of the dye in the late phase. So this is a pinpoint leak in the right eye, and this is the left eye is showing that the point leaks with pulling of the dye, suggestive of VKH or VKH in the bilateral serous retinal detachment. Swab's OCT showed a multiple serous retinal detachment, neurosensory detachment with subretinal septi. And ultrasound showed diffuse choroidal thickening, 2.21 millimeter. As you see, that 1.3 should have been normal. So it's almost a double. And patient, how did I treat it? I treated with the IVMP 1 gram per day for 3 days. Vision improved to 624 and 3/60. Started on 90 milligram oral prednisolone and tapered weekly by 10 milligram. Reviewed after 8 weeks, vision improved to 612 N12. And the posterior pole choroidal thickness, however, remains 605 microns in the right eye and 626 micron in the left eye. So steroids I maintain at 40 milligram till that vision comes back, and tablet azathioprine 50 milligram BD. Swab's OCT choroidal thickness was 2,230 micron in the right eye and 236 micron in the left eye, which is quite normal. Vision came back to the 6.9 in the right eye and 6/7.5 in the left eye. Now the question is how long we put the patients on treatment. As the patient is put on the long-term oral steroid, side effects are more. So I have put the patient on tablet prednisolone 10 milligram per day and tablet azathioprine 50 milligram twice daily for 6 months, and 2 months twice daily for 2 months, and once daily for 6 months. So about 8 to 9 months, I put the patients on treatment, and the patient had improvement of the vision. So what we have discussed is so far a case of sympathetic ophthalmia and Vogt-Koyanagi-Harder disease. So Vogt-Koyanagi-Harder disease is described, I don't want to be theoretical, described by the 3 ophthalmologists, Vogt, Koyanagi, and Harada, and this was combined now and is called a one disease called Vogt-Koyanagi-Harder disease. So there is a granulomatous panuveitis. You can see mutton fat KPs, broad posterior synechia, and serous retinal detachment. Both anterior and posterior segment is involved. They initially present with the neurological symptoms, and many of the times they go to the neurologist, and the neurologist first finds the disc edema, and they do an MRI of the brain or CT scan. They thought that it is describing an optic neuritis. So they don't do so they are not able to get the indirect ophthalmoscopy or other methods. So the disc edema is one of the many early features with the neurological symptoms in VKH. So they develop in the very late phase, poliosis, vitiligo, alopecia. These are the dermatological findings, and which you don't see in the active stage of the disease, in the heal stage of the disease. This vitiligo often disappears with the course of time. So what are the common differential diagnoses where you can make a mistake? The top on the list, you should not miss central serous retinopathy or chorioretinopathy, because the treatment is diametrically opposite. So if good fundus fluorescent angiogram is necessary in case of VKH, the reason is that I will show you a case. Other conditions like sympathetic ophthalmia, idiopathic panuveitis, posterior scleritis. Posterior scleritis is often unilateral and occurs in the female. Uveal effusion syndrome is closely mimics it, but you won't see the vitreous cells in uveal effusion syndrome. And the size of the globe might be non-ophthalmos or size of the globe is less. So this is a case. This patient presented with a serous retinal detachment, bilateral, and somebody treated with the oral steroid as well as the IV methyl prednisolone When I did the fluorescent angiogram, we found that there is a serous retinal detachment obviously, but there is a multiple point leaks were there. And this is the typical features of central serous retinopathy in multiple leak CSR with exudative retinal detachment. They can have the similar presentation. So how do you treat it? IV methylprednisolone, as I mentioned to you, high dose of oral steroids, slow taper, 1 to 1.5 milligram to start with. Immunosuppressive azathioprine, mycophenolate, mofetil, cyclosporine. If it is not responding, triple agent immunosuppressive steroid, azathioprine, and cyclosporine is given. Some reports are there today. Some reports are there recent time that treating with the biologic agents like adalimumab, infliximab. I don't have an experience with that. I put the patients on a steroid, IV methylprednisolone to start with, and then add immunosuppressive agents with the steroid in slow tapering. So this is my way I treat it. IVMP, high dose of oral steroid, immunomodulator steroid, duration of treatment, minimum duration of 6 months. I don't have experience of biologics treatment with VKH. So you need to, not only you need to treat the patients, you need to look for the complications. That cataract is 42%, glaucoma is 38%, subretinal fibrosis, and then there is a choroidal neovascularizations and cystoid macular edema. So one need to take care of the complication. Okay, Dr. Ajit Babu, in case if there is any questions in between, you can stop. It's a little non-formal way I want to talk.
Okay.
So there is a 2021, there's a new classification criteria for early stage VKH has come. This was necessary that because when the classification of VKH was made, that time Swepsos OCT was not there. So nowadays, every ophthalmologist or EV specialist do a Swepsos OCT or EDI OCT in case of sympathetic ophthalmia, and they do a serous retinal detachment with multiple pockets of serous retinal detachment and safety on optical coherence tomography. So these are the features which has been added with the new classification which has come from the Sun Working Group in American Journal of Ophthalmology 2021. And one need to rule out syphilis as well as sarcoidosis in case of sympathetic Wick-Wacht-Koenige Harder disease. Now coming to the another uveitic entity which is relatively uncommon in our country is Behçet's disease. I must have seen about 150 to 200 cases only, and this is a disease which is a chronic relapsing occlusive vasculitis of unknown etiology, and it's also a pan-uveitis. But what is dangerous in this disease is that the patient gets optic nerve involvement quite fast, occlusive macular ischemia, and the patient loses significant amount of vision. How do they present? They can present with a cold mobile white hypopyon. So if we see a cold hypopyon, no circumstantial congestion, you should look at the fundus to see that whether there is a vitritis, retinal vasculitis, or optic nerve lesion, papillitis, or optic neuritis. So they can have severe vasculitis, arteritis, and phlebitis, both are there, and they can have vitritis. So these are the ocular features, but they can have that other lesions. You should take the history of oral aphthous ulcer, multiple painful oral ulcer, genital ulcer, erythema nodosum, and dermographism, positive pathology test. These are the systemic features of Behçet's disease. And here, one test is very useful, is called fundus fluorescent angiogram. It will be top on the list, will be a fundus fluorescent angiogram. What we will find out is the capillary farning as is seen over there. And one can see also that macular area, the cystoid macular edema, one can see the optic hot disc, optic nerve inflammation. So the diagnostic criteria of Behçet's disease, one need to have an oral aphthous ulceration Ocular involvement can be anterior, posterior, or panuveitis or retinal vasculitis. And then FFA is typical of capillary farming and exclusion criteria. If there is no apoptosis, you should take very careful about labeling as Behçet's disease. So what are the tests has been done? A pathology test and HLA-B51. HLA-B51 nowadays is not that pathognomic, but pathology test you can do a simple test. And the diagnosis is vitritis, optic nerve lesion, as well as vasculitis. So how do you treat? Corticosteroid alone is not good for in these cases and is not effective at all. We need to treat with the immunosuppressive agents, either azathioprine. Actually, cyclosporine works very good, and biologics is the agent of choice in case of Behçet's disease. But unfortunately, many of our people in our country cannot afford biologics, which are quite costly, 6,000 to 8,000 rupees once in 2 weeks injection. So this patient, I saw about 15 to 20 years back when there was no biologics. I treated with a cyclosporine 5 milligram per kilogram of the body weight in 2 divided doses. The patient came from Punjab. This young lady got back vision. You can see that 1 week, 3 months, the patient's vitritis and retinal vasculitis resolved. So now I started using biologic therapy. This is a patient of, again, a case of Behçet's disease, vitritis, optic neuritis, and retinal vasculitis is there. And with that infliximab, there is a magical response. Everything resolved and the patient got back vision. But the problem is that when you stop the biologic agents, they sometimes comes back. So I have talked about sympathetic ophthalmia, Vogt-Feniger heart disease, and Behçet's disease. I want to talk about a relatively common disease called sarcoidosis. And sarcoidosis is a non-caseating granulomatous inflammation. So what it does is it produces multiple granulomatous inflammation. Copy nodule, which you have shown in this picture today, can also be present in sarcoidosis. Is more common in sarcoidosis than tuberculosis. Copy nodule or Buschakar nodule, large mutton fat KP, vitritis, snowball exudates. The intermediate uveitis is snowball exudates. We have recently described in Indian Journal of Ophthalmology intermediate uveitis due to sarcoidosis. There can be candleworks dripping, tachy boggy, candleworks dripping in the retinal vasculitis, and retinal vasculitis as such can be seen in sarcoid uveitis. Any retinal vasculitis is seen, one should do the workup for sarcoidosis, as well as a collagen disorder. So choroidal nodules is another feature of sarcoidosis. Optic nerve granuloma is seen on this case. This patient responded very well with methotrexate and steroid. So what are the laboratory tests which you should do? 4 tests I suggest. One is that 3 blood tests: serum angiotensin converting enzyme, serum lysozyme, serum or urinary calcium, and high resolution CT test. High resolution CT test and Mantoux test. Mantoux will be often negative. High resolution CT test showed bilateral hilar lymphadenopathy, which is called lambda sign. Raised serum ACE, which can be also seen in tuberculosis sometimes. Bronchoalveolar lavage will show the non-caseating granuloma inflammation. Gallium scan we don't do. And if there is an extraocular lymphadenopathy is there, one can do the biopsy and see the non-caseating granuloma. What's new? It's a very simple test has come in the newly to it is the lymphopenia as a predictor of sarcoid uveitis. This has come in the British Journal of Ophthalmology recently. And we have published, we have sent one article for publication with the lymphocyte count and serum angiotensin converting level in sarcoid uveitis. This is the revised criteria of International Workshop on Ocular Sarcoidosis has come in 2019. I don't want to go into the details of it, it's in the small print. But one of the things which I want to highlight is the gonioscopy can be very important. And you can see the trabecular meshwork nodule or tent-shaped nodule. You can see the snowball or pulse of vitreous opacity, optic disc nodules, and specific investigations, negative tuberculin test, raised serum ACE, elevated serum lysozyme, and lymphopenia, which has been added to it. So coming to the infectious panuveitis, which we come every other day we see, and I just give that acronym TV. There are three things: is there tuberculosis, toxoplasmosis, treponema, and viral. So starting with the tuberculosis, which is the bugbear, and it can be granulomatous anterior uveitis, broad posterior synechiae, retinal vasculitis with choroiditis as seen in this picture, multifocal sertiginoid choroiditis, which has been told by Asmita earlier, and subretinal abscess. There are two causes of subretinal abscess. Most common cause in our country is tuberculosis, but nocardia is another cause which can cause subretinal abscess. So choroidal nodules, tuberculum of the choroid, which you call, and it is tubercular uveitis. One should do a Mantoux test, which can be positive sometimes, and particularly necrotic Mantoux is strongly indicated of tuberculosis. Quantiferon TB gold test, but not a single test is diagnostic of TB. Chest X-ray, HSCT thorax, and intraocular fluid test. If there is a strong clinical suspicion is there, and all the tests are negative, you still suspect tuberculosis, you should do an intraocular fluid analysis, either anterior chamber tap, which is commonly done, and where you can get that DNA from the aqueous fluid and amplify it in 10⁶ times and do a what is called polymerase chain reaction. If we do not able to make a diagnosis, I think it would be a good idea in case to refer to a center where we can do the PCR testing to confirm or clinch the diagnosis. Systemic features of TB. This is a case which the patient has atypical presentation, frosted branch angiitis. This is an 11-year-old girl who has got abdominal tuberculosis, and the patient had retinal vasculitis. And this was treated with anti-tubercular treatment and steroid, and it responded nicely. So coming to that second T is the toxoplasmosis. Toxoplasmosis, I will also start with a case now. This 35-year-old male, HIV positive patient, sudden dimness of vision for a week. And when you look at the picture, you will think that it is a viral retinitis. But it was not a viral retinitis. The patient was found to have HIV positive, and it was the toxoplasma PCR was positive. So atypical panuveitis, you should think of toxoplasma also. Though the toxoplasma can present with the typical focal choroiditis with a headlight in the fog appearance or a by the side of the scar choroiditis lesion, but toxoplasma can in suppressed patients or HIV positive patients, they can present as retinitis. Now coming to that last infectious agent is the treponema. So this is a 43-year-old male, dimness of vision and floaters. He was diagnosed as CMV retinitis, and he was given with intravenous ganciclovir. He was HIV positive. I used to shake hands with all my patients when I call the patients and shake hands. So all male patients. When I shook hand with the patient, I found something wrong in the hand, something rubbing in my hand. And I found what I found, there is a rashes in the hand. That made me suspect that the patient is probably having what I found later on in the fundus is a syphilitic retinitis, subretinal precipitates with serous retinal detachment. And that indeed my suspicion was correct. RPR TPH was positive, and it was a syphilitic retinitis. Treatment with the done with the injection penicillin, and there was a marked resolution of inflammation was seen, and the patient got back vision. So syphilis is a one-time disease, and if you can identify the disease and treat it properly, it can be cured. So although it was an accidental finding, our mind has to be prepared. This is another case, 30-year-old male, and patient presented with a gradual dimness of vision in both eyes for 3 months. When I look at the eye, I found a large exudates in the fundus. It doesn't look like intermediate uveitis or past Panuveitis, but I couldn't guess the diagnosis. If you can guess the diagnosis, I think you would be a genius. And actually, I couldn't, and it was found out to be syphilis. So any atypical uveitis, you should suspect syphilitic uveitis and do both the treponemal and non-treponemal test. This is a pre-treatment and this is the post-treatment, so that this is such an amazing recovery is possible in syphilitic retinitis. Serological test for syphilis, both treponemal test like VDRL and non-treponemal test VDRL and treponemal test FTAVS or TPHS should be done. Ocular syphilis, as I mentioned, can mimic any type of uveitis. Order both the tests in suspected syphilitic uveitis. So take-home message is the uveitic conditions in syphilis should be considered as differential diagnosis. Serology is the mainstay of diagnosis. CSF analysis should be done, which all syphilis cases should be taken as the neurosyphilis unless proved otherwise. HIV infection has to be ruled out. Response to anti-syphilitic treatment. So coming to that V part of it, 3T I have talked. Now I want to talk about the viral one. Viral one is let's start with a case. This is 34-year-old male. He lost vision in one eye due to the chicken pox. And when you came to the only single eye which was having vitritis and retinitis coming from the periphery as it just approaching like a soldier to the attack, and it's a peripheral wedge-shaped lesion with retinal hemorrhages. So he say here is the diagnosis should be very prompt, rapid, and should we have a strong suspicion. If we have a picture like this, you should not forget second time that you have a case of a viral retinitis. In fact, this patient was on VZB was positive, ACTAP for PCR, for HSV, HZB, CMV was done, and VZB was positive. So acute retinal necrosis is like a wildfire, is a real emergency. We need to treat with the patients very aggressively with intravenous acyclovir, along with the intravitreal ganciclovir sometimes required, and timely barrage laser, which is often debatable whether it helps or not, but one need to be very aggressive in the treatment. So there are few emergency in uveitis, not like retina people or endophthalmitis. That's one of the emergency in uveitis is acute retinal necrosis. So fast diagnosis and management is required. So last is that masquerade syndrome. So masquerade syndrome in uveitis, you should not miss it. This is a 57-year-old lady. He was seen in one of the Apex Institute in the country. Painless gradual dimness of vision 9 months. He was diagnosed as tubercular choroiditis. For 9 months, he was on anti-tubercular treatment. But if you look at the carefully, this is not any pigmentation was not there. There's a leopard skin-like appearance. So we suspected masquerade syndrome, vitreoretinal lymphoma. We went ahead, Dr. Mahesh Shamugam did the fine needle aspiration biopsy, and the fine needle aspiration biopsy showed, you can see that what a large lymphoma cells were seen in the yellow arrow. It was an intraocular lymphoma. And in fact, our suspicion was correct. Diagnosis, MRI brain showed CNS lymphoma 6 months after patient died. But if we had made an early diagnosis and prompt treatment, one can give injection rituximab or injection methotrexate and can salvage the vision as well as the life of the patient for some time. So this is another patient, 51-year-old female, seen at Kolkata, blooding of vision floaters in both eyes, vision 6/6N6 in the right eye normal, left eye few cells. Fundus showed multiple subretinal nodule. Patient had joint pain and husband had pulmonary tuberculosis. So it directed to us as a tubercular choroiditis. We went ahead and ACTAP for PCR for MTV done elsewhere, and it was negative. And then we thought that we were dealing with some kind of tumor. Primary intraocular lymphoma was our first diagnosis. We did a vitreous biopsy. It showed inflammatory cells only. But when MYD88 mutation was negative also, but there was a strong suspicion of lymphoma, we went ahead and do a final aspiration biopsy exactly through the lesion. And it showed atypical lymphoid cells as seen in the top picture. And immunohistochemistry showed CD20, that is the B cell marker positive, indicating it's a primary vitreoretinal lymphoma. MRI brain was normal. PET-CT, no metastasis. Intravitreal injection of rituximab was given. Patient lived for quite a long time, but ultimately succumbed to CNS lymphoma. So lastly, don't miss endogenous endophthalmitis. This patient had history of admission in the hospital with intravenous infusion. And this patient had what he called is a endogenous fungal endophthalmitis, candida endophthalmitis with the contaminated fluid. The last case is a 44-year-old female diagnosed as intermediate uveitis in elsewhere, given posterior subtenon injection, and came with the urinary tract infection. I want to cut the long story short. He is told small, medium-sized keratic precipitate, AC cells, vitreous cells. Diagnosed initially was intermediate uveitis, spillover anterior uveitis. Patient had a disproportionate loss of vision, PLPR inaccurate in the right eye, KPs with fibrin, aqueous fluid 4+, cells 3+, with early synechia. Right eye, there's dense vitreous haze, no fundus view. Ultrasonography showed plenty of low reflective mobile membranous vitreous echo. Retina was attached. Advised to continue oral and topical steroid. And that worsened the situation. CT scan shows lymphadenopathy with apical lobe consolidation, infective, sarcoid, neoplastic, all the possibilities were kept. And here I want to highlight the patient was MANTU negative, less than 3 millimeter, which it was not directing us to tuberculosis. Serum ACE was elevated, ESR was 61 millimeter, quantiferon TB gold test positive, HLA-B27 positive, negative. So with reevaluation of the chest film done, strongly suspicion of TB, advised to review the physician for ATT. The patient 4 days later presented with the hypopia and intense fibrinous reaction. Started on topical steroid every 15 minutes, planned for IVMP even 1 gram for 3 consecutive days. Then later on, the patient presented with the granuloma, and it looked like endogenous endophthalmitis, fungal infiltrate. Our first diagnosis was fungal endophthalmitis. ACTAP done, PCR was negative for TB, bacteria, fungus. When we took the patient to the OT, we could find out the dense exudates in the vitreous cavity, lensectomy and vitrectomy done. Vitreous sample was sent for evaluation. And what we found in the vitreous is anybody's guess. And you can see that intravitreal vancomycin, cephalosporin, and dexamethasone given, thinking that this is a bacterial endophthalmitis. When he did that acid first stain of the vitreous specimen, we could find out that there was a Gill-Nielsen stain acid first bacilli, that the pink color bacilli was seen. What we thought that fungal endophthalmitis or intermediate uveitis turned out to be a tubercular pan-uveitis, which you should not miss. In our country, this should also always be kept in mind. So hypopia noted, intravitreal amikacin and dexamethasone given, and the patient after the second line ATT was started by the physician, intravitreal amikacin, dexamethasone given. Hypopia is the repeat intravitreal amikacin and dexamethasone was given, and then finally the exudate disappears and the patient got back reasonably good vision. So there are several cases of endogenous tubercular endophthalmitis and panophthalmitis reviewed as the case series, and we also added one case in this series. Another important thing is that one should not miss is the panuveitis is some Sometimes cystic sarcas, degenerated cystic sarcas can also produce, or toxocara can produce parasitic lesion, panuveitis. So there are practical points in panuveitis. One should remember most vision threatening. We need to take a careful history, tuberculosis, fungus, syphilis, immunocompromised status. Ancillary test is important. Laboratory diagnosis can confirm, and what is required in other forms of treatment, uveitis, an aggressive approach. So I think is quite a bit of time. I think we have got some time for questions. I hope I just want to give a panoramic view of panuveitis, non-infectious and infectious.
No, sir.
I once again like to thank you for giving us the opportunity. Let me stop
you gave
sharing.
you gave us an extensive causes for this panuveitis. A wonderful presentation, I would say. And you have not left any disease which has not caused panuveitis. So I think now it's open for any discussion. I think I request panelists to say, speak for yes. Dr.
Vibhuti,
Vibhuti?
yes,
Yeah.
please.
Yeah, sir. First of all, it's a fantastic and a very panoramic and a very descriptive coverage of what you were calling as very concise. It's not concise. I think it's pretty well covered. With your talk and with your permission, sir, I would like to ask 3 quick questions. It's
Please.
basically for my practice. So, sir, in cases of sympathetic ophthalmitis or in cases of Behçet's, or in cases of leakage, so for how long do you Behçet's would need a very long immunosuppression. So will a sympathetic ophthalmitis. So, sir, what is your cutoff point of a maintenance therapy of immunosuppression? Like, how long do you give a immunosuppression for a sympathetic ophthalmitis? How long for a Behçet's and how long for a leakage?
Sympathetic ophthalmia VKH, I do minimum 9 months treatment. But based on the clinical judgment, I may prolong it a little bit more. Behçet's disease is often a prolonged treatment for several years. So it even in the ocular features is controlled. The patient have underlying disease. So the dermatologist or rheumatologist wants to keep the patients on long-term treatment. So initially we give that biologic agents, then immunosuppressive agents, and then one can go to a simpler agents like colchicine or so.
Okay, sir. Sir, also when we're talking about the tubercular uveitis, in cases of panuveitis, wherein in the posterior segment where it is involving the macula, the patch is involving the macula, we often tend to give IVMP. But if we are suspecting TB, I mean, sir, what is the interval? Do we start? I mean, do you prefer to start the IVMP stat without starting the ATT or along with ATT? Is there a gap?
Oh, so my first aim is to salvage the vision. So I go straight forward, IVMP. I don't wait for that TB results. So once the TB results comes, Mantoux quantiferon HRCT chest, or my clinical suspicion is high, I would give anti-TB treatment. Patient would not lose vision for not getting the anti-TB treatment. Patient will lose vision when the patient is not getting anti-inflammatory treatment. So my first target would be to save the macula or optic nerve.
So, sir, if we want to go safe with it, can we instead opt for a local steroid like a PST or a dexamethasone implant like an Ozurdex? In such cases, I mean, PST would surely act later, but Ozurdex can act instantaneously as we would like to have. But it will have a localized effect rather than a diffuse immunosuppression, which may pair up the TB later.
Just now, 2 days back, I've given Ozurdex to a patient who has already received intravenous methylprednisolone. He was referred from Gwalior.
Yes.
And this patient was having one eye lost, other eye has got macular serpiginous choroiditis, already lost the 624 vision, and the other eye was counting finger vision. In addition to the IV methylprednisolone and the cover of anti-TB treatment, he was getting anti-TB treatment. I gave Ozurdex injection 2 days back, because Ozurdex will have a very high concentration of anti-inflammatory agent in the eye. and it will be like IV prednisolone, it will be a little bit more than that. So I will not get that. There is a series from PGI Group, Chandigarh, where they have given other under cover of TB anti-TB treatment, Ojudex injection.
Okay, sir.
So I have not many experience, but I have given 1 or 2 cases.
So, sir, can we think of Ozurdex as an alternative to IVMP if there is a
No.
severe contraindication?
No.
So because the Ojudex will act on locally in one eye,
yes,
there is always a chance of getting the other eye affected.
All right,
And
sir.
it's a
If
systemic
you
disease.
think about additive treatment, probably you can give intravitreal Vosodex in addition to systemic treatment.
Yeah,
which you
in
are
addition
giving.
to systemic steroid.
Sir,
Yes.
but in case my patient is just a unilateral case, how about that case? Because it will need it. I mean, it needs.
I would not say that alternative to IVMP. I will add Ojudex if there is in spite of IVMP is not working.
Which
But there are
unilateral
some
panuveitis you
reports.
are thinking, Vibhuti?
Yes, sir.
Which unilateral panuveitis you are thinking?
No, sir. In cases, sir, in cases it's a serpiginous like choroidopathy, where I am suspecting, so the way I diagnose clinically my serpiginous is like if there is an overlying vitritis. If there is a mild overlying vitritis clinically, I would strongly suspect a tubercular uveitis. If there is no overlying vitritis, but just a fuzzy margin, I would probably be more safe in thinking, okay, we can go for an IVMP. I will be more relaxed subconsciously to go for an IVMP. But if there is an overlying vitritis, mild vitritis, I would always be very wary. So in such cases, I always tend to think of trying for an intravitreal implant straight away.
No, let us not confuse the whole scenario here. What Jyotirmay Biswas was highlighting is that if there is a vision threatening, in those cases only you consider starting IV methylprednisolone or steroids.
Yeah.
But here the main etiology is tuberculosis. Without covering that, if you are opting for steroids, it can be a dangerous proposition.
Yes.
So at the earliest opportunity, you should start antitubercular treatment.
Yes.
Yeah. Sir, and my last query is, sir, for chronic cases like Behçet's, is it wise to go for repetitive injections of Ozurdex implants rather than going for an immunosuppression? I mean, both of them will have
immunosuppression will be working much better because Behçet's is a systemic disease.
Yeah. No, all the panuveitis mostly, you rule out infectious.
Yeah,
you should treat systemic more vigorous.
Yes.
That is more important. You should not think that it is only local or ocular. Okay, all this thing except for the infectious panuveitis, where he has very nicely highlighted that in addition to systemic therapy, infection should be targeted in these cases.
That's it from me, sir.
Dr. Subita Mahapatra, can you have some question? Dr. Subita?
No, sir.
Sumita, we are not seeing your face.
No, I don't, but it's not coming. I have started video, but still it's not coming.
Okay.
Dr. Ravindra.
Any other people?
Sir, regarding
Ravindra Kumar.
Yes, sir. As far as the diagnosis of this infectious etiology is concerned, when do you advise this intraocular fluid analysis? Can it be advised routinely, or most of the time diagnosis dilemma will be there? In that case, we are doing. And second thing, how to collect that sample? Can you just highlight that?
So I'll divide the question into two. When do you go for an intraocular fluid evaluation? My first will be the intraocular fluid evaluation is a Masquerade syndrome. So Masquerade syndrome, you cannot really make a diagnosis or start treating him without any tissue diagnosis, like in intraocular lymphoma, where the vitreous biopsy is or fine needle aspiration biopsy is of paramount importance. Second is the infectious etiology, like hypopia and uveitis, where you should not responding to that topical and systemic treatment, and you are thinking that it's not an autoimmune uveitis, it's not a Behçet's disease, and there is a history of in fever or etc. is there, or systemic infection is there. We're suspecting tuberculosis, fungal or parasitic infestations. We we should do an intraocular fluid evaluation. And particularly virus diseases where virus cannot be seen direct smear or culture, you should do PCR. A polymerase chain reaction is the only way to find out the virus. And in that case, if morphological diagnosis is not possible, you should go for an intraocular fluid evaluation and PCR. How do you collect for PCR sample? You need DNA only. So you need to keep the material without any preservative in an ice box and send to a center where it can be done. The DNA is it's not a fragile one. It's all often remains stable because we are not looking for cells. We are looking for DNA. The DNA particular organism, it should not be contaminated. It should not leak, and it should not get degraded by normal weather, normal temperature. So you should put in a cold ice box and send to a center without any preservative.
Thank you, sir. It is an honor for us to listen such a good advice from you, sir. Thank you.
Satyajit Sinha has asked some question.
Satyajit,
are you there?
How are you?
Satyajit,
If
you
are
can
there,
ask,
please do come.
unmute yourself and ask the question.
Sir, I was asking, sir, very nice presentation, sir. Good evening, sir. Very nice presentation. I wanted to ask in some patients, sir, with uncontrolled diabetes, sir, and these patients need systemic steroids for management of severe panuveitis. How do you go about in the management of these patients, sir, who have
I will
uncontrolled
go for
diabetes?
intraocular injection. I will be going for intraocular injections, or I will go for immunosuppressive medication. Mostly, I will go for an intraocular injection after ruling out infection.
Satyajit, in case of both sympathetic ophthalmia and VKH, and if the patient is highly diabetic, probably you need to take the physician. Initial, the bolus of steroid is very much required in these cases to get the control of the autoimmunity in these patients. Initial 2 weeks or 3 weeks. After that, simultaneously start an immunosuppression. Definitely, immunosuppression takes some time to take over.
Yeah.
During that time, steroids can be given. Once the immunosuppression takes over, you can reduce the steroids drastically.
So what happens is that one of my patients who was 450 milligram per deciliter blood sugar, it was not getting controlled. As Dr. Ajit Babu Maji is saying, that in every way you should try to treat the systemic steroid, but some rare situations like diabetologists can be controlled the steroid by insulin, giving the blood sugar under control, and you can give a steroid. But sometimes, since once in a while, it might not be possible. We have reported a case where we have given injection triamcinolone in the vitreous cavity of a VKH patient. The vision threatening, and it worked well. So, is the injection Tricort is a short-acting steroid, and it can be given in situations. We have reported one case, but it's not the order of the day. Is to give control the blood sugar and give immunosuppressive as well as the steroid as soon as possible, as much as possible. The reason is that it's a systemic disease. It's not a local disease. VKH sympathetic ophthalmia is a systemic disease. It's often bilateral.
For the benefit of the postgraduates, I wanted to ask a question. If there is a case of uveitis and you are not sure what it is to begin with for your diagnosis, the clinical working diagnosis, what are the tests you would like the postgraduates to advise to begin with to try to get to somewhere? What are the initial first few tests that a PG should ask for, sir?
I would simple start with the total WBC count, platelet count, and then we do that in our country. I'll rule out the TB and sarcoid first. I'll do a Mantoux, quantiferon, and chest X-ray, and if possible, quantiferon TB gold test. If possible, high resolution CT test. The two things I am top on my list is the TB and sarcoid. And toxoplasma can be diagnosed by clinically itself because they have got very classic appearance of headlight in the fog appearance or a choroidal or a retinitis by the side of a pre-existing scar. So it's not a much difficulty. So I would like to order total WBC, platelet, and liver platelet and TB test. Mantoux, quantiferon, TB gold, and probably serum AC I will add. And if it looks atypical, I will add VDRL and PPHA.
Thank you so much.
So I think Dr. Shubham, one of the PG students, has to ask any PG student. Dr. Shubham?
Yes, sir.
Do you have any queries, anything you want to make?
No, sir.
Dr. Mega was silent.
Yeah.
Sir, in case there's a negative history for back pain, can we avoid testing for HLA-B27 in the initial visits as a primary investigation?
HLA-B27 is not a diagnostic test. It's a case of a confirmatory test. A case of uveitis, anterior uveitis, like hypopian uveitis, fibrinous anterior uveitis, you won't defer your treatment regimen based on the HLA-B27. So what we do is the HLA-B27 will tell you that what would be the future of the patient. If it's a positive, then the patient will have multiple recurrence, severity on recurrence. You should tell the patient that you would have chance of recurrence. Keep a bottle of Predfort in your freezer and start putting that prednisolone acetate when you develop photophobia.
Okay. Okay, sir. Thank you.
I think
Biswas, you must have seen a lot of cases which are either referred or come to you with VKH. In your experience, what are the reasons for recurrences?
So the VKH is that the treatment of the recurrence occurs when you don't treat it. You have to hit hard at the beginning. You have to hit hard at the beginning. If you fail to hit hard, it goes to the chronic stage. Once you go into the chronic stage, it would be really so. It says the initial first 10 overs is the most important. Is that in the cricket match what you call is the initial. If you don't start it, later on it would be too late, and the patient will get relapsing chronic uveitis, secondary glaucoma, iris bombay, cataract, choroidal neovascular membrane. So, but if you hit hard, you will not get even sunset glow fundus. So, initial IVMP makes the trick. I have compared the study of analysis of 87 cases of VKE, where we found that the patient presents within 1 month of onset of symptoms. These patients do well. Then the patients were coming after a month. So in our country, unfortunately, many of the patients do not be able to reach the diagnosis or treated with the topical steroids and or steroids in a low dosage. So that often lead to a chronic stage.
Another important this thing is intraocular lymphoma, which most of the people really misdiagnose. Yes. So how do you suspect at the initial stages? What cases you have seen is like real advanced lesions were there in both the cases which you have described.
Yeah. So there are 3 situations where you suspect intraocular lymphoma. Over 50 years of age, patient having vitritis without significant circumciliary congestions, photophobia, only vitritis, and which is not going with the steroid. 2 weeks, 4 weeks after it's not going. That's one situation, number 1. Situation number 2, when I don't see pigmentation with choroidal infiltrate, instead of choroidal lesions, is a choroidal infiltrate without any pigmentation and without some leopard spots like things which I see that one, that would be seen. And if it is progressing too fast, there multiple lesions is emerged, then I will suspect primary intraocular lymphoma. And these are the patients should be treated in a tertiary care center if there is any suspicion, because that vitreous biopsy is required, final aspiration biopsy is required. Fortunately, they are not that common.
And whatever Satyajit asked regarding uveitis, only I would say that you should have a very clear clinical pictures in your mind. If you are not clear about uveitis, it's better to send to a specialist, uvea specialist, rather than advising battery of investigations.
Great.
You should make a short differential diagnosis,
Yes.
3-4 disease,
Yes.
and then go for TB, sarcoid, syphilis. These 3 tests. And then instead of ordering an NCA for a choroiditis patient or HIV for a choroiditis patient, serpiginous choroiditis. So you don't need to do a battery of the test or stool or urine examination in a case of subretinal abscess.
So I think it's time now.
Yeah.
How often intraocular lymphoma leads to intracranial lymphoma or any association between the two?
I couldn't follow.
He wants to know about the ocular lymphoma, and there is ocular neurological. Yeah.
So actually that intraocular lymphoma we see more often.
Yes.
Than that patient coming with a CNS lymphoma. When the patient comes with a CNS lymphoma, the diagnosis is not difficult. Is the Hodgkin's disease or non-Hodgkin's lymphoma coming in the CNS, and the patient coming with a ocular involvement, then there is no diagnosis is not difficult. And even you don't need a vitreous biopsy in such cases. You can tell that one, you take care of if the biopsy prevents CNS lymphoma, you don't need to do a vitreous biopsy.
So before
70% of the cases are ocular lymphomas, actually.
Yes.
And only 30% will have CNS involvement.
Yeah.
Whenever there is a CNS involvement, usually there will be a systemic features will be accompanying.
Metastasis will already be there.
So comments from President EIZOC, Dr. Mayor sir.
Actually, this is a very expensive discussion, and Dr. Jyotirmay Biswas had elaborated in a very good way, and we thank him from EIZOC side and all the participants and our mentors and chief coordinators. I thank you everybody for this grand success of this webinar.
I'm glad that we are right in time. 10 o'clock.
Yes. So to conclude,
one more question postgraduates can ask.
Yeah,
any postgraduate.
Any question, anything, and you want to have some discussion? Lija, then Aisaria, anything you want to say something, or you want to put your...
You can add anything also.
Yeah, that's why I'm asking. Lija?
Sir, I had a question. So, sir, the patient was a 13-year-old female with chronic granulomatous uveitis with a tubercular origin. And on examination, there was anterior uveitis with cells, flare, KP, and posterior synechia. And in the posterior segment, we found vitritis. But sir, we didn't find any lesion in the retina or the choroid. The FFU was normal. So, sir, in that case,
I would consider it as an intermediate uveitis with spillover anterior uveitis. That would be my diagnosis.
Spillover anterior uveitis.
I would rule out TB and sarcoid.
Okay, thank you, sir. We had been very okay.
So
we were very confused with the diagnosis, sir. Thank you for clearing that out, sir.
I think it's time for a vote of thanks. Before a vote of thanks, I would like to ask Subodh, Mr. Subodh, our host, entered host, to play the video, that usual video we played before the vote of thanks. So, Mr. Subodh, our host.
Okay, sir. Just
Yeah,
playing.
your video, please. Entered Pharma is our host today. They host this webinar, and I think they are regularly doing. Thank you, and thank you, Enter. So before vote of thanks by Ashok, I would like to say a few words. As from the discussion, we've seen that Panuveitis is a very common disease. It is a major cause of blindness and visual morbidity. And the prognosis for the people with Panuveitis varies depending upon the underlying cause and its severity of the disease. When the condition is unrecognized or missed, diagnosis very much missed, or inadequately treated, profound and irreversible vision loss can occur. So early diagnosis and early detection of the disease, clinical features, early diagnosis, early investigations can and with the proper management can prevent this severe case of a blinding disease called Panuveitis. So these are my comments, and I think I will ask Dr. Ashok to say the vote of thanks to our great speaker and all the panelists. It's over to Ashok.
Thank you, sir. Though I joined a little, but uveitis is something where how many times you hear, you learn new things. So I'm really thankful to Professor Biswas for clearing a lot of doubts in discussion and also in his talk. And I thank all the coordinators who organized this interesting ORTS program, Professor Subudhi, our Majid Babu sir, and Sabeshji Bhai. So I thank you for doing this for the help, for the benefit of all the doctors, residents, and even senior people who are not very familiar with topics which are being discussed. And finally, I also thank Entered for their support, which has always been there. Thank you. Thank you all, and good night.
I'd like to thank you all for giving me this opportunity, particularly Dr. Subodhi and Dr. Ajit Babu Maji. I'd like to thank Dr. Sapasati Patnaik, Dr. Satyajit Sinha for being with us. I'm looking for going to Patna, Satyajit.
And we need your expertise once more also in coming days. Thank you, sir.
Actually, it's very extensively covered, JB. It's very nice lecture on Panuveitis, because if anyone who has attended, they would have understood the Panuveitis in a very greatest detail you have given. And hopefully, all the postgraduates, you have made a good notes of it, and don't stop here.
Yes.
Tomorrow you read about Panuveitis for next 2-3 days. He has covered everything, but it will brush up all what you have listened today. Okay. And if you see, the presentations are very classic, and what he has given you is very clear clinical pictures to identify different entities of Panuveitis.
Yeah.
So it will not be any confusion for you in the clinic.
And mostly the
you
cases.
should be able to start the treatments in Panuveitis cases. And from
Dr.
today onwards.
Yeah, Dr. JB is present a lot of cases. That is very important. A lot of cases is presented. Yeah.
Right. Thank you, JB. I think we will wind up.
Good night. Good night, everybody.
Good night.
Good night to all. Bye. Bye.
Thank you. Thank you all.
It's time for dinner.
Thank you.
Thank you.